Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, it's Mark Graban here. Welcome to episode 435 of the podcast. It is January 12th, 2022. Our guests today are Dr. Sunil Khushalani and Antonio DePaolo. And I should say they're both doctors. We have an MD and a PhD. We have a psychiatrist and an engineer who've done great work together applying lean in the mental health care delivery setting. They are co-authors of the new book called Transforming Mental Health Care. So today we're going to have a conversation about lean in mental health care, what they've learned, what they've done. And I think more importantly, there are lessons that come from the realm of mental health care that'll be helpful to anybody doing lean work in any setting. So for links and show notes to get a discount code to buy the book through their publisher, you can find a lot more by going to leanblog.org/435. Thanks for listening. Now here's the episode. Well, hi, everybody. Welcome to the podcast. My guests today are the co-authors of the new book. It was released in December 2021, titled Transforming Mental Health Care, Applying Performance Improvement Methods to Mental Health Care. So our guests today are a physician, a psychiatrist, more specifically, and an industrial engineer. So as an industrial engineer, celebrate that. Our guests are Sunil Khushalani. He, again, is a psychiatrist who specializes in addiction psychiatry. And we're also joined by Antonio DePaolo. He's a PhD, a transformation executive and Baldrige Fellow, who has more than 22 years of experience in improvement science. So Sunil and Antonio, thanks to you both for joining me. How are you?
Thank you for having us on your show.
Congratulations on the release of the book. I had a chance to read it earlier last year, I think it was, before it went to print. It's a great book. I hope people will check it out. You know, there's a big market out there, I'm sure, for people trying to do this work in mental health care settings, but I think some of the lessons from the book are going to be real broadly applicable. So we have an opportunity to explore that today. The book, I noticed on Amazon, has endorsements by Dr. Don Berwick from IHI, notoriety, of course, Dr. John Toussaint, Professor Steve Spear. So it's a very impressive list, and I'm honored you'd also ask me to review the book. But you can hang your hat on those other blurbs. That's very impressive.
Yeah, all four of you, at least for me, were some of the heroes that I looked up to, or it helped me in understanding this whole field myself. So I was very, very thrilled when all of you, decided to review the book and write a blurb for us.
Well, there are three people I certainly look up to and have learned a lot from. So I'm glad they like the book as well. So we're going to have a chance to dive into what you shared in the book and take a glimpse into that here today. But I'm going to start off with a question that I ask most guests, because you have different backgrounds professionally and with your degrees. I'm always fascinated to hear people's lean origin stories, I think, as we've come to call it here. So Antonio, maybe we'll start with you.
Sure. So my lean origin story, as an industrial engineer, we spent a fair amount of time talking about lean and Six Sigma and performance improvement in our curriculum, but then going to work in a General Motors factory, as well as working with Delphi Automotive and learning and working within their global lean group, I really learned from a lot of folks who were very immersed in their specific craft, whether it was queuing theory or quality theory or production systems or ergonomics. And then after that, I went to work for a company, Stanley Tools, where they used Shingujitsu consulting. And I had a sensei from that consulting group where I learned more of the finer details of lean thinking. And it was just a great honor to learn from folks like Sensei Nakao and some others, and how they approach the entire, improvement science, and really kind of leveraging that to accelerate flexibility and speed within an operation. And so 16 years of experience in manufacturing, and then I moved over into healthcare to, start a new chapter, if you will.
And Nakao is legendary, of course. I've heard a lot of stories about him. I've never had the opportunity to learn from him directly or meet with him. But at General Motors, so one thing we share in common is, I started my career at GM for 2 years, 1995 to 1997. And people might say, well, how much could you learn about lean at GM or Delphi? But even in those years and years after, GM had a lot of knowledge. They had a lot of success stories. I was fortunate to have the second plant manager I worked for was one of the original NUMMI people. So, that knowledge was there within GM. It sounds like you were able to tap into that as they were trying to spread that throughout the company.
Correct. Yeah. A lot of folks that were, highly engaged in the NUMMI project came to our facility and really helped us understand, the finer points, and we were able to implement successfully.
So Sunil, let's turn to you before we'll go back and hear about Antonio's shift into healthcare. You're, of course, a physician, a psychiatrist. How and where and what were the circumstances for you being introduced to lean?
So my first introduction came, one of our vice president at Shepherd Pratt, where I was working, was taking an MBA course at Hopkins, and he invited one of the professors there. His name is Chip Davis, to come and give us a course on leadership in patient safety. And one of the articles that he passed in the course was Steven Spear's article, how healthcare can fix itself from inside in HBR. So that's the first I heard about lean and about Toyota-based methods being used in a hospital. I happened to find the book Pittsburgh Way, in my library, and devoured it. Excitedly went to our vice president. We had another vice president said, they're offering a course in Pittsburgh. Why don't you go and take the course? So I asked my vice president to come along with me, and both of us went to take the course, a 4-day course. It was called Perfecting Patient Care. I think Steve Spear and Paul O'Neill were kind of, consultants to this consortium in Pittsburgh. And to me, those 3 days, I literally had insomnia. I mean, I could not sleep because I could see so many applications of this way of thinking to what I was seeing every day in my day-to-day practice. Fast forward, as you get immersed in this, you start learning about Virginia Mason, John Tuison's work at ThedaCare. We came across your books, Dr. Berwick. I became a member of the IHI and, got to know Don Berwick's work. So, all of you kind of were path breakers for us, for me especially, to kind of follow along and constantly keep bringing this back to my workplace. And for the first 2 years, we worked with PRHI, which was a group that taught us the course. And then, we were advised to have our own internal expert. And that's when I contacted you, I think, in the past, and you had connected me to Styles. And through Styles, we came to have Antonio, referred as one of the people. And that's how, the whole, everything gets connected, all the dots get connected,
So, and it's funny, those dots of Styles Associates, recruiting firm that focuses on lean. I've known Ted Styles and Jake Styles and them for a long time. They've been a sponsor of the podcast, so people may have heard a little ad for them at the beginning. But so it's good to know that there's that connection. When some of these other names that you mentioned here, the Pittsburgh Way book is one that I really loved. Nada Grundin, who is the author of that, has been a guest on this podcast twice, and I'll put links to that in the show notes. Steve Spear has been a guest here many times, and he's amazing. And then I'm really happy to hear you mention Paul O'Neill, who passed away in 2020. He's been incredibly important and influential to me, as many in healthcare. So Sunil, what was the time frame of your first discovery, your first introduction to lean?
In 2009. 2008, 2009. Yeah. In that time frame.
Yeah. So that was still, I would put that in maybe still the early adopter part of the curve. Do you think that was especially true for you in mental health care settings?
Well, absolutely. There was nothing in that space, at least in a form of a publication. I think there was some work being done in NHS. I think NHS had invited, Dawn Berwick and Mark Gray, the CEO of Virginia Mason, Gary Kaplan, to go and advise them. And they had two sets of books. One was, I think they initially called that whole series The Productive Ward, and then they retitled it as Releasing Time for Care. So these were both lean applications that they had incorporated into NHS. And I think that was also one of the earliest publications I saw, but there was very little about mental health care there. The only other book in this space was published by Health and Hospitals Corporation and Oxford University Press. It was called Lean Behavioral Health, which was a story of this Health and Hospitals Corporation applying lean principles to their hospital system. But we tried to take a different approach to the book, in the sense we didn't want to make it about our hospital's journey, like there were many other books in that way. We thought, if an independent practitioner or if an independent administrator were to want to apply something like this to their own work, what could they learn as basics? And that would kind of open their minds to waste or value or things like that. So that was our approach to the book,
Mm-hmm. Yeah, and HHS, you mentioned they're in New York City, and for those who don't know, Shepherd Pratt is located in
Baltimore,
so it's down the coast a ways. Antonio, let me turn it back to you, because Sunil mentioned how you were, brought in through Styles Associates. What are some of your recollections about making that first step or leap, into healthcare, making that transition?
Well, I went into the deep end of the pool, so to speak. Most people start in general healthcare. I went all the way into mental health care. And it was really an interesting time to come into a space where a lot of the answers to my questions were maybe. And so it was rather challenging. And it was kind of like, coming into a kind of an open canvas, if you will. And so it was an opportunity to really, kind of paint the system of improvements for this system of care. And so that appealed to me. The other thing that appealed to me, I think, was the fact that these were experts in behavior. And as you know, a lot of what we deal with in the lean world is behavior, right? Because it's those behaviors that are driven from culture, which are driven from leadership, right? And so if we want to improve the results that we get, we have to really drive at those behaviors. And so it was an opportunity for me to learn from the foremost experts just around behavior theory and how to approach it. And so it was one of those things that you look back and you say, this was a perfect match for somebody like myself to immerse myself and really learn more about my craft.
I think it's always great when you can combine in any circumstances, clinical backgrounds and engineering mindsets, and kind of weave together different levels of expertise. But that behavioral health dimension to it is even more intriguing. It's an opportunity, perhaps, Sunil, maybe let me turn this to you, an opportunity for those who are leaders and practitioners in behavioral health to practice what you preach when it comes to organizational behavior. What are some of your thoughts or experiences on that?
So one of my most remarkable experiences was, I had first met you in the Mid-Atlantic Conference in Timonium, Maryland. In the same conference, I met Ron Oslin, who was another, he was a lean coach, executive lean coach for Capital One at that time. And he and I, happened to go to dinner that night. And he asked me, what do I do? I said, I'm an addiction psychiatrist. And, his first question to me was, how do you change people? And, that led to our discussion on, stages of change and motivational interviewing. And, he was very intrigued by that idea. I think he later on went on to create an entire way of teaching this in a workshop format. But that discussion started in a restaurant in Timonium, and he actually even mentioned my name when he was called to give the keynote speech the following year, saying that started in that conversation. And so for me, it was very interesting to see his thinking was that executives that he was coaching were addicted to firefighting, addicted to status quo, and they didn't really want to take this long approach of empowering people, going to the front line, helping people create a learning organization. That was too long an approach for them. They wanted quick results, quick wins, and he felt that was antithetical to this kind of system. So it was really amazing for me to be able to share notes with him about what I would do as a person to apply these ways of changing patients to, learning systems or to learning organizations. So it was a very interesting conversation.
Yeah. Yeah. And motivational interviewing is something I've been able to cover in a couple of episodes where I've interviewed people. And I was introduced to that topic, that approach by a social worker, maybe going back 7 years ago. And I've taken Ron's workshop, as you mentioned, and there's a free webinar that he did for the Lean Enterprise Institute. I'll try to remember to put that in the show notes so people can Google it. I've been trying to get Ron to be on the podcast. If I do, I can ask him his side of, I guess, what is his motivational interviewing origin story.
Yeah, sure.
It's funny how many dots there are to connect amongst the people we've come across and learned from in different directions. And when he teaches that method, motivational interviewing approach, he uses that phrase, addicted to the status quo. So I'm curious, maybe you first, Sunil, then your thoughts, Antonio, based on what you've learned. My parroting back of, I think, what I've learned, and please, correct me or elaborate on this, is that addiction is characterized by a situation where you have reasons to change and you have reasons not to change. And we continue doing something even though we know it's probably net bad. And that's the challenge. Can you talk a little bit more about that dynamic of addiction and how you see that in leaders as opposed to people who are getting treated for clinical addictions?
So if you think about patients who come for treatment or who are referred for addiction treatment, the majority of patients fall into two categories. The first category are called pre-contemplators. These are people who are not even aware that they have a problem, or they are in denial of the problem, or they minimize the problem. Then there is a next group of category that have been informed or that have somehow realized that there might be some problem, but they're ambivalent. So they are in this ambivalent phase of their life. So they have equal and opposite forces. One side of them wants to stay the same. One side of them wants to change. And any direct attempts at telling them to change invokes a resistance on their part to stay the same. So if you tell somebody who has been drinking a lot or who has a alcohol use disorder, you drink so much, he would tell you all the reasons where he doesn't drink so much, or like my friends drink more than I do, or nobody, I'm the person who can hold my liquor, all these things. So similarly, I think when you approach physician leaders or people in medicine, it's very hard for them to move from an individual dynamic, like when you are a doctor and there's a patient, there's a one-on-one dynamic, to a systems dynamic. I mean, this whole notion of thinking about the whole system of care, thinking about how you're set up, thinking about the whole value stream, thinking about the journey of a patient from start to end. We are not trained to think like that. So when I first came across, the system of profound knowledge by Deming, and he has these 4 components. The first thing is like systems thinking, and most of us are not trained to think that way. And so there is the typical reaction to any problem is to do more conferences, to do consultations, to go to the library, to go do research. But nobody kind of tells you to kind of take a 30,000 foot view and look at the whole system and is it designed correctly? Like, so when Antonio comes to a place like this and asks somebody, well, why do you do this or why do you do that? The commonest answer after maybe is, well, it depends. It depends on this, it depends on that, but nobody has specified those parameters that can be easily, invoked.
Sure. And I think just to piggyback on that, I remember one of the first things that Sunil asked me to do was actually watch his process. And so I spent some time watching this doctor-patient process. And after about 3 or 4 hours, he asked me, so what'd you think? And I said, well, about 35% of what you did was waste. And just like we just spoke about of people not knowing how much waste is in their process, I think, Sunil, you can talk to it, but I think you were kind of blown away about how much waste was embedded in this process. And
I think before that, there was a relationship between me and Antonio in the sense that he and I had come to know each other or get comfortable with each other. I had understood waste value. I was primed at PRHI.
Yeah.
So for me to see those 8 wastes, evident in my own day-to-day work, it was almost like the water I was swimming in. I was completely oblivious to that. And the light bulb went off, and then you can see, yeah, this is wasteful, that is wasteful. I need to have a no interruption. Every time I would go out to take a phone call, I would be interrupting the patient. Then I would have to restart my computer. Then it would take 2 minutes to load up. All these wastes were completely things that I was oblivious to.
So to dig a little deeper, Antonio, what you were observing was that, what was that like in an exam room setting? Were those counseling?
Yep, it was an exam room. Yeah.
Okay.
Basically 8 to 10 patients, I think he had at the time, and he was running through each patient, doing admissions as well as follow-up work with each of these patients on a unit. And so I was just there observing his process and noting, where there were pockets of waste. So it was just a way for us to, because what we like Sunil said, we did establish a good relationship and rapport with each other. But Sunil kept asking me, how do you make what your implicit knowledge, how do you make it explicit? How do you show me what you know? And so it led into all of these conversations about, well, let's go take a look and let's go learn together. And so that's where that came from.
Well, and one thing that comes back to mind of thinking about motivational interviewing, and that process starts with building relationships and rapport, and not just jumping right in and I think they use the phrase, the writing reflex kicks in. You need to stop drinking so much. Well, wait a minute. Who are you to say you don't even know me? Would lead to a very natural sort of resistance. And I think there's risk of that also in a workplace. Like, there's that instinct to tell people what to do or to tell them they need to change. But, bouncing it back to you, Antonio, thinking about Dr. Deming and the system of profound knowledge, and there's systems thinking and there's also psychology. So you were bringing in systems thinking. I'm curious to hear more of your reflections on learning more then about psychology and behavioral health, because it's eye-opening when you step back and think about how we used to go about things. Right.
And certainly in the manufacturing world, you're working to improve at such a fast pace that sometimes you skip some of those behavioral pieces, and it can short circuit your ability to gain long-term improvement. And so it's really, when I talk about mentors, Sunil was a mentor of mine at Shepherd, and certainly helped me understand some of the motivational interviewing pieces, the stages of change, and how to approach this. So we are working to build a bridge, if that makes sense, to everyone in the organization, so they can take a step forward. And it's not a matter of them understanding me; it's a matter of me understanding them. and really working to, meet them where they're at, and to think about even the language that I use. I came in with a lot of buzzwords on lean and a lot of Six Sigma terminology. And Sunil was like, yeah, take all of that and put it off to the side, and really just simplify this so folks can understand what it is you're trying to say. And then we can work on building it from there. And so that's what we did. We built an entire course that was really centered on behavioral health, in relation to lean thinking. And with that, folks really gravitated towards what we were trying to impart.
Yeah. I mean, I think people like learning from examples that they can relate to.
Absolutely.
Not just a healthcare example, but like if it's people in veterinary medicine, they want to hear veterinary medicine examples. People in laboratory medicine want to hear lab examples. Sunil, you were about to add something.
Yeah. So I think every conference that I was going to, one of the commonest presentations I would see would be sessions on sustainment being a common problem. That there are so many lean shops and lean hospitals, but there's no Toyota. I mean, that was a common theme. And that everybody gets the technical piece all right. They understand 5S and they understand A3 and they understand that. But getting people to adopt it is a problem. So it's not a technical challenge anymore, and it's an adaptive challenge. And that's where, I kept thinking, well, there's so much in our field in psychiatry where we are dealing with this all the time. We are telling people, here's the right medicine for you, here's the right therapy for you, here's the right program for you. And there is all this resistance. And almost everything we do in psychiatry to overcome that resistance could be applied to lean thinking or applying to the challenge of sustainment or the challenge of getting people to, the whole change management field and psychiatry are like, cousins that probably need to meet more often,
Right. So stepping back a little bit to 2008, 2009, when we talk about motivations, you're learning about lean, but, what, like organizationally or personally, what were the motivations or the reasons why lean was interesting and something that you were driven to figure out how to adapt to the mental health care setting?
So I think it was a time in my career where I had taken on some managerial or leadership roles. And in doing so, I was coming across in meetings and hearing about quality problems, safety problems. So I was generally curious about what have people done to solve these problems. And the answers from that, Stephen Spear article was there is a whole wealth of knowledge of how people have gone about solving quality or safety or delivery problems. And so then I said, this is a whole new world to me. And once I discovered lean, then I started reading more. I was very, very fortunate to have somebody like Antonio mentor me and, became like my sensei at Shepherd Pratt, correcting me, saying, you're giving all the answers in the class. You need to hold yourself back and stop giving people answers. You need to let people figure this way out. And it's not about you figuring everything out. It's about them figuring it out along the way. And I think it became a constant learning theory, going and applying it to work. We did like 3 big things at Shepherd Pratt. One was a course that we designed together, which was a course basically teaching people how to apply A3 thinking to their problem, which was a safety, quality, delivery problem at Shepherd Pratt. The second thing we did was we instituted, some like Kaizen activity or some 3 or 4 day event. So that was the second way in which we tried to transmit this kind of thinking. The third thing we did was we established lean daily management boards or huddle boards on many of our inpatient units. So we were constantly seeing the application of those things in this space, and each unit became like a microcosm into itself, giving us different challenges, different resistances to kind of work with. And, in some places we succeeded a lot. Some places we had somewhat of a moderate success. In some places we didn't succeed. And it was like a mixed bag. But, we were dealing with the whole normal distribution curve of some early adopters, some late adopters, and most people like waiting to see what everybody else is going to do before we're going to jump on,
Yeah. Well, and then, just going back to what you were saying about wondering how people are solving problems, I think there's also a progression from looking for solutions, looking to journal articles or conferences or courses, of going and taking solutions to plug in versus the solution being a process for problem solving.
Correct.
Which is a different level solution. And that's where the A3 use and teaching and everything comes into play. And that's as much a behavioral tool as it is a technical tool. Yeah. I think in terms of like the coaching through an A3, not just following a template. What are some of your reflections, either of you or both of you, on sort of like, coaching people through effective problem solving?
Yeah, I think, we found that a lot of folks wanted to, as we were teaching the A3, wanted to kind of rush through the process. And you can see they would get all the way down, even into root cause within just in their office, right? And so we would start, asking.
Or they would come to the class with a pre-specified solution that they wanted to retrofit into an A3.
Right. So that's the coaching.
Yeah, and I think it's interesting because a lot of leaders, they end up becoming leaders because they're good problem solvers, right? And so then they enter our course and they want to provide a solution to a problem and then put it on a piece of paper. But what we do is we back them up and we show them how to go through this process, because lots of times when they're actually going through it the right way and involving their stakeholders, they learn some things about their own problem that they didn't really think about. And by just taking that step back, they actually come out with much more clear, much more concise solutions than what they would have come up with on their own. And so I think that was one of the bigger takeaways that I've seen through this process.
Yeah, two other things that Antonio observed that, one thing he felt was, especially in psychiatry, that we had a very verbose culture. People love to talk, people love to chat, people love to, swap stories, anecdotes. So there was a lot of this anecdotal thinking, but there was not a very systematic, data-driven approach to things where you look at, aggregates or, things like that. And measurement was something that a lot of medical professionals actually struggle with. And, figuring out more sophisticated ways of measuring things was hard for them. And again, most people had no training in that. And even to do something simple like a Pareto chart or something like what you have in your book, Measures of Success, to look at common cause variation or, special cause variation, those were really advanced concepts for many people, even in healthcare.
Mm-hmm. So let's talk a little bit more about some of the things that you touch on in the book, and we can come back and discuss other lean topics from your experience and your work. In the book and in the material about the book, there's a statement there. So 1 in 5 Americans experience a mental illness each year. And that data is probably pre-COVID. So I'm interested to know if you could fill in a little bit of detail there of, what would be the most common form of mental illness that people experience, and how much of a challenge is there where people, for whatever reasons, don't get access to the right treatment for that?
So I think the commonest disorders that you would see probably would be anxiety and mood disorders. Those would be the commonest disorders that are almost ubiquitous, and almost all of us have been through some times in our life where we have suffered from very difficult, anxious or sad or melancholic moments. I think as the stigma towards mental health has declined over the years, even now there's a lot of stigma, but as it has been declining, the acceptance of need for mental health treatment has been growing. And because it's a very labor-intensive, experience, like most psychiatric care happens one-on-one, like, where you're sitting with a therapist or a psychiatrist one-on-one in sessions that can last anywhere from 15 minutes to 30 minutes to an hour. And most people have chronic conditions for which they come to see a psychiatrist or a therapist. There's not enough people, there's not enough, person power to solve all these problems in such a labor-intensive way. And of course, the constant challenge is that you hear from people today is, I want to see a psychiatrist, but the earliest I can see one is in 8 weeks from now or 6 weeks from now, or there's a huge waiting list, or people, ERs are clogged up, or, places are clogged up waiting for a psychiatric bed because there is no psychiatric bed. So this is going to just worsen. And yes, some tools have come about because of the pandemic, like telepsychiatry or telemedicine has come about in a big way. But there is so much waste, I think, trapped in how the labor is used or how the workforce is used. Like two big examples. One is the amount of documentation a psychiatrist has to do, or a psychiatric practitioner has to do in a hospital. Could be literally 40 to 50% of my day is spent in actually documenting what I'm actually doing. So even if you were to cut that down by half, you would increase your workforce by an additional 25%. Second, the whole promise of electronic medical records has really not seen, the benefits have not been translated easily to mental health care, because as you can imagine, a lot of mental health care has to do with narratives and what you say to me, what I say to you. Unfortunately, almost all billing, all these EMR software are billing driven, and they want to see 8 points of this and 4 points of that and 6 points of this for you to be able to bill something. And again, if I had to see a new patient in the paper and pencil world, it would take me 45 minutes to see a patient and maybe 15 minutes to write up my note. In the modern electronic world, I was spending 45 minutes seeing the patient and almost 30 to 40 minutes typing that note. And so much of time is trapped in just sheer documentation, which is a huge problem, I think, for this country. I read somewhere, I don't have the source right now, but even comparing USA to Britain or to UK, the notes are 3 times as long in the US because of defensive medicine or because of fear of malpractice or because of third-party payers. Everybody wants more and more explanations, direct quotes, more examples. And the note becomes so large that most people are spending all their evenings with a laptop just documenting notes. We call it's euphemistically called pajama time, where you're wearing a pajama and writing notes.
Yeah. It sounds like there's a very full fishbone diagram to be filled out of many bones of answering this question, a high level question of how many people or why don't people get access to the right treatment, like you say, stigma, lack of access to appointments, could be insurance or other coverage issues. So it seemed like that access challenge, in addition to safety and quality, you'd think would be a big motivator. But you can't just tell someone you're over documenting. This comes back to the questions around behavior change or looking and asking why.
There's tremendous organizational inertia. Like, if you try to document less, then people who do coding or people who are in the compliance world, they say, no, Medicare will not allow this, or Medicaid will not allow this. You have to document all these 20 lines for me to justify that this code is appropriate for you to bill for. And so we are all nobody wants to bell the cat, and everybody's no matter which audit you come out of, whether it's a Joint Commission audit or a CMS audit, at the end, 3 or 4 things get added to your note, and the note just gets longer and longer over time.
Yeah, and what, just to kind of piggyback on that a little bit, what Sunil is describing is there's a constraint in the number of resources that we have in mental health care. But I think what I've come to appreciate over my time working with Sunil and at Shepherd Pratt is that mental health care is primary health care. And, if you think about all these chronic conditions folks have, mental health is one of the major contributors to many of these healthcare conditions. So, just thinking about that and appreciating that, understanding the constraints within the healthcare field, I think there needs to be more emphasis around trying to improve the system of care.
Sunil, one question, and this is not necessarily a lean question, but just to close some of that discussion on mental health. If somebody is listening or they know somebody who is questioning if they should reach out for mental health care, like when should they reach out? Like if they're questioning it, is that a sign at least to reach out? Should they talk to their primary care physician, or what do you recommend is like a first step?
Absolutely. I think 80% of mental health care is delivered by primary care doctors. In fact, in all the new payment models to do a PHQ-9 or a GAD-7, these are like small, simple screening tools for depression, anxiety. They have simple screening tools for addiction. I think it's absolutely perfectly okay to talk to your primary care doctor. One of my common things that I would tell all my residents and students was, don't worry alone. If you have some worry or some difficulty that you're going through life, talk to somebody, and it could start with a friend or a family member, but it could then expand the circle to a physician or a primary care doctor. And at some point, if the problem is persistent or disabling or chronic, you will be referred to a professional. And there is no shame in it. Just like you could have a disorder of the pancreas, you could have a disorder of the brain that is leading to these problems.
Yeah. Well, thank you for that, Sunil. So one other thing I wanted to dive into a little bit more, you mentioned lean daily management. Antonio, maybe I can bounce that over to you. That's a phrase we hear a lot, or variation of that phrase in healthcare and beyond. How do you describe lean daily management? What are some of the main principles or components of that?
Sure. So the way we set it up at Shepherd, and it's different in every organization that I've been at, right? We set it up a little bit differently in each one because we wanted to tailor it to the environment that we're in. Again, trying to build that bridge. So at Shepherd, we said, okay, let's focus on one safety, one quality, one delivery metric or problem that we're trying to solve that relates to that specific unit. So where we might have a psychotic disorders unit that's focused on trying to ensure that they keep all of their staff and patients safe on that unit, a very big, important piece. And so they wanted to focus on, violence reduction, whereas a geriatric unit doesn't need to focus on that, right? They need to focus on something different, maybe orthostasis or ensuring, the elderly don't fall unnecessarily, right? And so they have a different focus. And so what we did is we said, let's ensure that the local team can establish what those priorities are that are important to that team and to that unit's success. And so that's how we established each one of these boards. And what we did is we set up a cadence where the leadership team would basically round on these units with those local teams to just see how they're doing with their improvement process. And, if there were any needs that they had that particular day. And it wasn't a leadership rounding thing. So we told local teams, if the leadership team is late by 1 minute, you are not to wait for them, right? And so you are to just do your thing. And if we're there, great. If we're not, keep doing your thing and we'll catch up. And so we made it a very unit-centric approach. And because of that, they really owned it. And they drove it. And so we wanted to make sure it wasn't just another PI process improvement initiative by this improvement team off on the side. It was something that was owned by that unit, by that team, and they cared about it.
Just like, Gawande says in his book, better count something, so basically we were teaching people to start counting things, putting it on a run chart, do a, red or green chart to say, was it a green day or was it a red day? Do a little bit of root cause analysis and come up with an action plan, make an actual spreadsheet and see who's going to monitor what by what date, make them more accountable. So that whole problem solving process got embedded in this day-to-day solving of problems.
Right. Right. Yeah. And that's where it seems like there are parallels between what you're describing there, between good A3 problem solving. There are parallels, I think, it seems, to the motivational interviewing approach, where instead of just focusing on the actions, you talk about the motivations. So that can translate into goals and measures for the organization, and then work with people to figure out how are we closing those gaps in performance.
Right. And using good, kata-based questions along the way to help them learn. And through that learning, they become, self-actualized and are doing this process with their teams. Whether or not Sunil or I are there, they're continuing that process.
Yeah. Well, and that's a good sign it's becoming part of the culture when they're continuing that process. We're not filling out A3s because someone told us we had to. They're filling out and using A3s because they're finding them helpful. And,
right.
And that's exciting to hear.
I mean, when Antonio came, there was no such department. Today at Shepherd Pratt, there's a whole department of operational excellence. There are 6 or 7 industrial engineers working there. I'm sure they could hire many more, but the fact that there is a full-fledged department, a space, a time, resources given to that, it's creditable,
So I'm curious to talk a little bit more, with the book you mentioned the challenge of burnout, and we talk about motivations and reasons for lean. I think trying to create workplaces that lessen the risk of burnout. That's an important motivation. Having fewer people quit and leave the field. We know that was a big problem before the pandemic. It's getting a lot more attention because of how the last 2 years have gone. But I'm curious to hear your thoughts on burnout. I mean, like, for one, is that categorized as a mental health issue, quote unquote, or is that an organizational career issue? I'm just curious how you categorize that.
I mean, I don't think it has made it to the diagnostic and statistical manual or as a diagnosable condition. Although, burnout is a more non-specific term that could lead to depression, or it could lead to anxiety. It could lead to, substance use disorder. It could lead to people just, impulsively quitting their jobs. It could lead to those problems, but it's more of a meta phenomenon that is, like a funnel that can bring about other, or trigger other more deep-seated problems, or and have a much broader effect on the workforce. I think what I've come to appreciate is that so many of the solutions that are proposed for burnout initially that were coming out were all driven towards the individual. Okay, you need to take care of yourself. You need to exercise more. You need to have a work-life balance. You need to do mindfulness courses. But today, after work of people like at Mayo Clinic, people who are studying this more realize that it is as much an organization's responsibility to create the right conditions for working and to involve and engage people in solving these systemic problems as a recipe to, get a more engaged workforce, to have less burnout, to have less of these, chronic and persistent problems. And Antonio was able to do that in units which had a very high turnover. Like, he worked with a unit which almost like a very high percentage of people quitting. And after 3 or 4 months of talking to them, understanding what their constraints were, working with the manager, creating an environment where they were solving these little problems, the manager was able to see a much more engaged workforce, and the turnover plummeted from like very high numbers to less than 10% within a matter of 6 months.
It went from like 75% turnover to less than 3% within 6 months, and it stayed that way for over a year and a half.
That's great. That's great. And I love the way you frame that, Sunil. We'll bring it back to Deming and the idea of systems thinking.
Yep.
You're right. It's silly to blame individuals for their reaction to systemic problems, especially when those reactions tend to be pretty consistent. I've talked to nurses and doctors over the years who I tend to agree with them when they scoff at the idea of being sent to resilience training again. Like, I'm glad to hear that people are realizing that the organization can improve the systems instead of trying to help people just deal with it one way or another. The more provocative language that Dr. Deming would use, he would talk about, we've built these prisons of a management system, we can change them.
That's right. Just today morning, I was reading Masaki Imai's book, Gemba Kaizen, and one of the phrases that really struck me was the management needs to create elbow room for Kaizen. And, that creating that elbow room is such a big lift for today's management to have this kind of fragile endeavor of doing Kaizen work possible. And to me, that's what we write about in our last chapter of the book is initially when this whole endeavor starts in an organization, it's a very fragile thing. Anytime there's a budget problem or a financial problem, that's the first thing that people will look to, like, oh, this is not needed. But to me, that's exactly where your solutions are going to come from. That's exactly where these seed ideas are going to come from that will have, a beneficial effect for your firm later on.
That is definitely true. And I think there's similarities of thought. Don't blame your employees for not speaking up. Look at systemic issues of maybe why they don't have the psychological safety to speak up. Because I've found in every single workplace I've gone to, people have ideas. Yep. They know what the problems are, right? So if you hear leaders scoff and sort of say things that are blaming, or my employees don't have great ideas, they probably do. So we can step back and look systematically. And I think there's a common theme here. Don't blame people for systemic errors. Don't blame individuals for systemic burnout. Don't blame people for resisting someone else's idea. So Sunil, you mentioned earlier, I was going to ask you to elaborate. You talk about this sort of this reaction. You tell me to do something. You tell me I need to change. I'll tell you reasons why I don't need to. Or can you talk about that a little bit more in the context of how that's almost to be like an expected, natural human reaction?
Yeah. So the idea is to take the person's, what we say in motivation interviewing is that I may be an expert on addiction, or I may be an expert, in psychiatry, but you're an expert on your life. You know what diets are manageable by you. Like if you're somebody who, depends on somebody else to fix a meal for you, you're not going to eat a Mediterranean diet because you're going to eat whatever they give you. So we can sit in our, a high pedestal and say, you need to do this or you need to do that. But I need to understand from you, what are your life circumstances? What are your contexts? What is it that you want to achieve? You may come to me with 4 different problems of drinking, smoking, being overweight, having diabetes. And I have to ask you, is this something that you have the bandwidth to work with? And you might say, my eating is fine, but I'm really drinking too much. And it's okay, let's talk about how much are you drinking and what is your goal? And you may say, I don't want to be, once I take 3 drinks, I don't know when I take the 10th or the 11th one, I don't even realize that, and so I may say to you, like, what can you do? And they may come up. So the idea of motivation interviewing is that the answer, what you need to do. It's my way to show you and coach you on how to get there. Similarly, in systems thinking, as Antonio and I discovered, most people who were at the workplace, they know what is the problem. They'll say, like, every 2 days we have a staff shortage and you expect us to do a lean daily management. I really don't have the time to do that. So we would say, like, I completely agree with you. Unless your staffing is stable, these are all luxuries, for you to think about. So I think, so that's where the management responsibility comes in. That's where the leadership responsibility comes in, is to, what can you do? Like the inverse pyramid that, Imai talks about is like your role as a manager, as a leader, is to support the Gemba, or is to support the workplace. And are you doing a good job of that? Or are you just sitting in your boardrooms and looking at the numbers and saying, well, we need to cut staff here and we need to do this or do that? And is that really your role? And to me, I think, again, talking about what John Tuisand always talks about, is one of the most challenging things is to get leaders to look at their standard work, or to look at their day-to-day habits, to see if what they're doing to actually support the workplace.
Yeah, those are all really good points. And I think back to, this question of, asking people for input and not taking ownership of a problem away from them. I think those are great problem solving practices or habits for leaders or lean practitioners. And I'll add, I think what you've added there's this list, I should type this out at some point, of don't blame people for ... I would add, don't blame people for being resistant to change. They're being human. And I think as soon as we label, like, they're resistant. Well, like, no, like, don't brush people aside like that. Don't label them. You need to keep engaging, I think, is the lesson. That, to me, that was one of the most powerful takeaways of motivational interviewing.
it's a very natural reaction to anybody trying to change your habits, your neuroplasticity, your way of thinking is, I tell people, this is how you fold your hands. Try to do it in a reverse order and see how difficult that is or how odd that feels.
Right.
Even such a simple change feels awkward. So to imagine that you're going to change your entire work pattern or entire way of seeing patients, that's a very big change you're expecting people to do.
Yeah. And people are going to ask why. So to do that exercise, if you tell me, cross your arms the other way, before I even try it, I might say, Sunil, why? Come on, why? I don't want to. It's not even, I don't want to. I don't understand the problem. I don't understand. And to me, this comes back to A3 thinking of like that upper left portion of the A3 before we get anywhere near the root cause analysis of just understanding what's the background, what's the context, why is this important? That's, I think, a powerful parallel to motivational interviewing as well. So as we wrap up here, before we get final thoughts, the book, again, it's titled Transforming Mental Health Care, Applying Performance Improvement Methods to Mental Health Care, co-authored by Sunil Khushalani and Antonio DePaolo. So we got the MD, PhD, physician, engineer combination. That's great to see. So the book is available now through Amazon and other outlets. Maybe as a final thought, I'd be curious to hear one other lesson learned. Trial by fire, lessons learned of trying to apply these methods. There are a lot of successes that you've pointed to. Or is there kind of a pitfall or a lesson learned that comes to mind, something you've learned from along the way, from the challenges, the real challenges of doing this work?
So one of the lessons I learned about sustainment was each area where you're trying to deploy a new technical solution is a new PDCA. That was my learning the hard way. I tried to do the same thing. I tried to share results from one place to excite somebody else. But as Antonio said, their problems may have been different. They may have had a different starting point. Maybe taking care of belongings was important to one unit because they were losing a lot of belongings of patients. But maybe that was not a problem to a different unit, and they had a different problem that I needed to work with. So my first question when I work with a manager today is, tell me what stresses you the most. To me, that's where we need to start. So I follow that easier, better, faster, cheaper order and say, I want to make things easier for you, for me to explain to you what is really going to make this come alive for you. And if I can make your day easier, if I can reduce some of your burden as a manager, as a leader, as a doctor, as a nurse, then you will understand why this method is important and why I'm so excited about this method.
Thank you for that, Sunil. Antonio, what do you have?
Yeah, I think it really goes back to originally why I joined Shepherd Pratt, and what we really got out of it was the relationship side of improvement is really, in my opinion, the cornerstone of lean, and really building that is essential for this type of thinking to work. And so that was really the biggest lesson learned is, you can't just take this stuff from a manufacturing environment and throw it right into a different sector and think it's going to work. You really have to work to build relationships. You have to build a bridge. You have to learn about their environment. And then through all of that learning, there can be a collective kind of approach that is adapted and works for that environment. And so to me, that was really the biggest lesson learned along the way.
Well, thanks. And thanks again to you both, Sunil and Antonio. Congratulations again on the book. I hope people will go check it out. Again, it's Transforming Mental Health Care is the title. And I hope people will check it out. I mean, maybe if they're not working, if you, the listener, aren't working in mental health care, I know there'll still be lessons for you to draw from the book to apply to your own setting, or maybe it can help your organization find a sponsor within the mental health care area to bring you in to help, because it certainly sounds like there are big opportunities. So thank you for highlighting some of the opportunities and how lean and performance improvement methods have been helpful. Really, really appreciate it.
Thank you.
Thank you.
Well, thanks again to Sunil and Antonio for being guests today for a great conversation. To learn more about them and their book and more, go to leanblog.org/435.
Thanks for listening. This has been the Lean Blog Podcast. For lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.